All right, thank you very much. I'm going to focus on children and adolescents today. I have no significant disclosures. I'm going to start by briefly providing a review of the context of HIV, both in children and adolescents globally, as well as in Brazil, and then review approaches and considerations for children and adolescents, discuss antiretroviral treatment, including strategies and goals for treatment, and provide an update on the latest research. So globally, as of 2020, this is data from the WHO and UNAID. What we see here is that accounting for new infections in 2020, children accounted for 150,000 new infections at that time. And what we've seen globally is that nearly 40 million individuals are living with HIV. There was a decrease by 31% of new infections since 2010. And in the Americas, we've seen that decrease has been by 6% since 2010. And so most of the new infections that occur, or the infections that do occur in children and adolescents, occur through perinatal transmission. We're seeing less and less of that over time, as well as during adolescence and young adulthood through sexual contact or drug use. The first pediatric cases occurred in 1977, and what we see here as shown to I won't use the pointer. To the right of this graph is that there was really an increase in new cases that were predominantly through perinatal transmission, less so through transfusion-acquired cases. And the median survival at that time was just over 9 months. And what we learned from that was that there was a significant natural history of HIV after initial transmission. Without treatment, symptoms developed over months to years, with 25% rapidly progressing to clinical AIDS in the first year of life, and 75% of individuals experiencing slow progression, with a 25% mortality of up to 5 years, and the annual rate of disease progression at 6.8%. So when do you consider HIV, particularly in children and adolescents? Well, there are a number of conditions that may present that you should think about, particularly failure to thrive or poor growth, as shown here on the bottom. So someone who has short stature is not making their milestones, general lymphadenopathy, lymphopenia, impaired, delayed hypersensitivity reaction, as well as recurrent or unusual infections, delayed puberty or a halt in puberty, a lot of skin conditions as shown here at the bottom, particularly nearly 90% of individuals will experience a dermatitis without treatment that can be anywhere on their body, as well as parotitis, as shown here. You should think about this also with sexual or other types of abuse, and with a sibling who has been recently diagnosed. What about adolescence? So we think about adolescence as a period of time where there might be sex, drugs, and rock and roll, as we say in the United States. And in Brazil, what you see here is that this is based on in-country data, that among adolescents, about 8% of females and 20% of males had actually had sex before the age of 13 years. So that's defined as early sexual debut or early sex. Individuals who had ever had sex overall was anywhere between 30 to 45% of adolescents. And among students who have ever had sexual intercourse, those who did not use condoms at the first time of their sexual intercourse was quite high, as shown here at the bottom. So these adolescents are particularly at risk for HIV if there's inconsistent condom use and they're having sex at an early age. We also see in Brazil that the birth rate is about 71 per 1,000 births for adolescents in this age group, which is much higher than adults. And only half of individuals that are 15 to 24 years old report having appropriate or adequate HIV knowledge around transmission or prevention. There are key vulnerabilities in adolescence that need to be considered, particularly in Brazil. Young transgender women are particularly at risk for high HIV. And in 2017, the country profile for Brazil suggested that 30% of young women who identified as transgender were positive for HIV. With high testing awareness, about 77% had been tested, 71% described condom use at last sex. Despite that, recent studies by Veras and a sample of over 500 transgender women found that HIV incidence was almost 4 times higher among younger adolescent women than older women, and almost 6 times higher for women that described exchanging sex for a place to stay, or income, or safety, or drugs. The next population to really think about are young, same-gender loving men. In a sample of over 2 million Brazilian young men, there was an HIV prevalence of 18%, high testing awareness, but lower condom use during last sex. And so when counseling young populations, we have to really consider not only their partners, but also how they're engaging in condom use. As we know that age discrepancy, older partners can put younger partners at risk for HIV. In a study by Gomeris, in over 4,000 young men who have sex with men, only 24% had adequate HIV knowledge. And what was associated with knowledge, or rather lack of knowledge, was younger age, non-white skin color, so individuals that identified as Black. Exchanging sex for money, again, was associated with lower knowledge, as well as other risk factors. So what is adolescence? Adolescence is really this unique period, and as mentioned, I'm an adolescent specialist, so this is the time that I love. There's really that period of cognitive development, and this is when adolescents are really thinking concretely. So what does that mean? That means that sometimes they can't think abstractly to plan for condom use in the future. They think A plus B must equal C. And if every time they do A plus B and it doesn't equal C, then they don't think C will ever happen. And that C can be HIV. So because of that, it's often a hard time for them to plan in advance to prevent such consequences as HIV. Identity formation is also key during adolescence. So during the same time of trying to gain your cognitive and your emotional development, you're also trying to be more autonomous and more independent and think on your own. And so this is often in the background of a lot of risk, and so that can create some increased vulnerability for adolescents. And then psychosocially, adolescents are often influenced by their peers. So they're much more influenced by their peers during the middle part of adolescence. And later in adolescence, they come back to resonating with their family. But it can take that vulnerability of risk for them to actually come back to the period of resonating with their family. And during that time, they may feel invincible, or that they may not actually feel like they can get STDs, sexually transmitted infections, or HIV. And at the same time, we often let adolescents have less supervision, so we're not necessarily paying attention to every action that they're involved in. So when you're seeing a child or an adolescent, it's really important to think through, all the aspects that I've talked about. The context of that adolescent, where they're coming from, what their vulnerability might be, but also their developmental and their developmental stage. It's important to get a complete medical history, including a detailed social, family, and travel history, complete physical examination, laboratory evaluation, confirming their HIV status, obtaining baseline laboratory data, and then referring for additional support, so housing support, mental health, substance use support, and then establishing goals. Trying to get on the same page with the adolescent is really important and really critical during this time. So really understanding how much they understand of the diagnosis, what do they need to be successful, and then what are their goals for their care. When you start seeing someone at this age, you really want to confirm, depending on the age of the individual, their HIV status with an antigen antibody test, an HIV viral load, the CD4 count, genotype and integrase testing if it's available to you, complete blood count, chemistry, urinalysis, glucose 6-phosphate deficiency, as well as syphilis testing, tests for tuberculosis, and other serologies. So when do you start? So this is the 2021 UNAID WHO guidelines, and where Brazil is in those meeting those guidelines. And what you see here is that the recommendations are that treatment initiation thresholds among adults and adolescents should occur regardless of CD4 count. And initiation in children should occur regardless of age. So when do you start? Start as soon as possible in everyone. Rapid or same-day start is not yet approved based on these guidelines in Brazil. However, there are high priority groups: less than 3 months, pregnant women, patients with HIV-associated nephropathy, and individuals that are co-infected with hepatitis B or hepatitis C. And you always want to use a combination ART regimen, 2 NRTIs plus an NSTI or an NRTI or PI. Consider possible resistance, avoid treatment interruption if possible, and use the best regimen for your patient. So sometimes you have to take into account that they may not be able to take multiple pills, or they may have difficulty swallowing, and so you have to consider all those factors. So here are the guidelines again, and as of 2021, dolutegravir, or DTG, was the first line ARV for adolescents and adults in Brazil. These are the Department of Health and Human Services guidelines that were released in 2022, just to show you what's to come and what the possibilities are. And so just to highlight a few things in yellow, one is that recent FDA approval actually has allowed for formulations including Biktarvy, or bictegravir, emtricitabine, and tenofovir, alafenamide. And so now that is considered the first line regimen for anyone that is over 14 kilograms, or over 2 years or over. Also, abacavir plus lamivudine, or FTC, was described as the preferred dual regimen for individuals aged over 3 months or older, or full-term infants up to less than 3 months. And that's shown here at the bottom. Okay. And then up here, what you see here is that FTC TAF was recommended for individuals that are weighing greater than 14 kilograms. And that is actually in a co-formulated tablet in the US. And then for children, doravirine was also available in a co-formulated tablet in children over 35 kilograms or more. So you really have to consider some key factors: comorbidities, drug-drug interactions, whether or not it's palatable, whether or not someone can swallow, has side effects to the medications, their adherence, and how to support their adherence. So we use pill boxes, phone reminders. We have navigators that will check in with patients or do video conferencing to ensure that daily observed therapy, even if someone can't come in and can't be seen, can be reached. And so you want to actually follow individuals to check their viral load or their responsiveness to the medication. One thing to consider is resistance. So there have been a few studies that actually have demonstrated that high resistance was particularly found in children that had been exposed to PMTCT therapy. And so this is really something to consider when you're actually starting medications in this population. There are other things to consider as far as adolescents and adherence. So psychosocial, as I mentioned, their desire for autonomy and risk. HIV stigma continues to be a barrier, mental health and substance use. There are logistical barriers that may need to be considered, particularly low literacy and ability to understand what you're actually prescribing or the regimen that you're working towards, as well as all the other psychosocial factors I mentioned: housing, unemployment, medical mistrust, which actually is a key area that we're experiencing in the US that you may also be experiencing in Brazil, as well as discrimination and racial bias. Emotionally, lack of maturity, lack of the ability to plan, as well as treatment fatigue. After some time, patients actually just don't feel like taking medications every day. And that can vary from person to person, and so you really need to take that into consideration as well. There are many interventions that have been studied, particularly different types of support systems in place: phone reminders, text reminders, computer-delivered interventions. There are some that actually have used in-home nursing in addition to mobile applications, particularly the Tech2Check study, and then multi-system approaches. Just to highlight one of our studies here that I've had the pleasure of leading, which was a motivational-based coach study, where a coach actually texted with the youth and also provided motivational support. And we found that youth were really focused on reaching their own goals. They wanted to actually find a job, improve their health. They didn't actually want to focus on taking on medications. But by using this strategy, we were able to address mistrust, and then help people get into treatment. So looking forward on the horizon, there are a couple of other things to consider. You heard about the Capella study earlier, which was a lenacapavir phase 2-3 study. And so adolescents and adults 12 years and older who actually had been heavily treatment experienced with multi-drug resistance were either enrolled into a randomized control trial or non-randomized arm, and then receive lenacapavir versus placebo PO. And at the 52-week data, what you see is that the lenacapavir in combination with their optimized background regimen actually had high rates of virological suppression and low rates of virological failure. So this is on the horizon for children as well. And then the Atlas 2M study, including cabotegravir and rilpivirine, also demonstrated comparing Q8 week to Q4 weeks, and found that there was higher virological failure with the Q8 weeks, or every 8 weeks injection, versus the Q4 weeks, but still very, very good outcomes. And in adolescents, this was released in 2022 at CROI, really finding that PK levels were very similar to adults for individuals that were on the cabotegravir and rilpivirine intervention. So beyond ART, how do we support adherence? So that was just a snippet, a snapshot of modalities that are coming that we're using in the U.S. in adolescents, and really getting adolescents on long-acting injectables, because some adolescents really have a hard time actually maintaining oral adherence. And so we have to consider all those factors that I talked about, the cognitive, the psychosocial, the emotional development, which is key, but also think about multimodal, multi-strategy interventions to meet the needs of adolescents, and really consider all those background factors. And with that, obrigado.